Hello and welcome to this fourth masterclass. It's part of our electronic patient records masterclass series for nurses, HPs and midwives. I therefore would like to welcome back those of you that have been to the previous two sessions. I'm going to talk a little bit about what we covered in those sessions for those of you that are new, just so that we'll whet your appetite to go back and look at those videos as soon as they're released. So a little bit about how the masterclass programme has come about, and then I'll introduce you to our speakers and we will dive straight in. So the rationale for this masterclass programme really has come around from the Frontline Digitisation programme, and myself as a CNIO in the southwest of England. I recognised that there were several organisations that were going to be adopting EPRs, and in discussion with my other regional colleagues in the UK, we thought that we would open these sessions up nationally so that they were available to nurses, AHPs and midwives even before that you start your procurement journeys, to really aid your development and your preparedness for what is a major change in your organisations. And those of you that have been through major change in your organisations know that winning hearts and minds is really important, which is what this session is all about. In terms of attendances, we usually have about 250 people signed up to these sessions, with about 100 attending, so there might be lots of comments coming through and lots of questions. We'd certainly encourage you to put questions to our panel. If we have lots of questions, we will just release a few of them and we'll try and deal with the other questions offline outside of the session with getting information from our speakers that are here today. Behind the scenes, we have Sam Selick, who is the Associate CNIO in the South West region, works with myself, and she has been the person who's been keeping in touch with you, setting up all of the system and emailing out your invites. And after the session, she will email you a little bit about what we've covered. So next slide, please, Sam. Just going to say a few words about the first couple of sessions. So session one was very much our introduction session where we talked about the EPR journey end to end, and I pick out a couple of critical messages that came through. One of them is about having real clarity about the benefits that you expect to get from your EPR system and what you need from your EPR system, and therefore the importance of early engagement from clinicians into making your business case, into your procurement process, are absolutely important, because these systems are predominantly and primarily for you as the clinician using these systems. If you're going to get the benefits out of them, absolutely critical you're involved from the beginning. And from session two, which was all about go live, key messages, involvement of your executive team, significantly involvement from them, absolutely critical to success. The development of your relationships with your suppliers. I think it was described as sometimes it gets a bit bumpy and that relationship will be tested, but really important to forge that bond from the outset. And then the critical role of well-managed cutover and a command centre managed go live. So these were the things that we covered in the first couple of sessions, and hopefully that whets your appetite once they're available to go back and watch those if you didn't manage to catch them. So straight into today's session is understanding behaviour change for EPR adoption, and we have three wonderful speakers with us today. Helen Balsdon, who's the head of digital nursing in NHS England and works to Natasha Phillips, who is the CNIO for England. Professor Dave Thomas, who is, I have to look Dave's title up always because it's so lengthy, and I'm only going to do some of it. Interim Director of Nursing Strategy and Transformation and CNIO, that's ever such a mouthful, Dave, and Claudia Trainer, who's a psychologist working in the Behavioural Science Unit of NHS England. Welcome to our speakers, and I am going to leave you in their very capable hands. Hand over to Claudia now. Thanks, Sam.
Thanks, Sam. Thanks, Dorothy. It's lovely to be speaking with you all today. So as Dorothy mentioned, myself, Helen and Dave will be taking you through some of the factors to consider from a behaviour change perspective when we're trying to encourage EPR adoption. So if we move to the next slide, I'll give you a quick overview of how we're going to structure the session. So first, I'll run through how we might try to understand behaviour change, so some of the approaches and tools that we use within the Behavioural Science Unit at NHS England that hopefully you'll be able to apply for EPR adoption in your own remit. And then Dave will take you through how you might stack the odds in your favour, taking you through some of the experiences he's had on projects in the past. And finally, Helen will talk about how fundamental the change is that's required, some tips and tricks on how you might be able to help people join you on that journey. So if we move to the next slide, I'd just like to start off with a quick exercise to get us started. So if you look at the slide, you'll see two flower shapes. And what I'd like you to do is look at the central orange dot and try to see how they compare. And for most people, the dot on the right-hand side will look bigger than the dot on the left-hand side. However, if we use the animation, you'll see once we remove the petals around these two dots, actually they're exactly the same size. And the reason that our brains think the one on the right-hand side is bigger is because we're using the context in order to make our perception of it. We're not thinking in absolute terms. The environment really matters. And our brain makes shortcuts like these all the time. And what's really interesting is that even though we now know that these dots are the same size, if we use the next animation, we can see that as soon as we return the dots, the surrounding petals, we can't unsee it. And this is just an optical illusion. It's obviously very simple, but it's happening in the real world as well. So on the next slide, we'll see a real world example. And this is one, if you've seen my colleague Dan Berry speak, he likes to go to, but I think it illustrates the point quite nicely. Here we've got people who've paid for a gym subscription, who are going with the intention of doing some exercise, and yet they're choosing to take an escalator instead of a very short flight of stairs. Now, if you ask them at the top of the stairs, why do you do that? Maybe they have a huge fear of stairs. Maybe they love escalators. Maybe they want to save their legs for that workout. But in reality, it's probably a lot of other factors that they can't necessarily describe that are probably influencing them. The very fact that they see other people doing that, the fact that the escalator's there, how they're feeling in that moment. And in behavioural science, what we're trying to do is to understand these often underappreciated factors that might be influencing how someone behaves so that we can try and get to the desired outcomes, so people can follow through on what it is that they're actually wanting to do. We all have very good intentions. We aren't necessarily always able to follow them with our behaviours. On the next slide, this brings us to a core concept in behavioural science, which is called dual system thinking. There's lots of different ways that people talk about this, but one that's very commonly used is system 1 and system 2. So system 2 is reflective, it's controlled, it's effortful, conscious, slow, rational. This is the way of thinking and deciding what to do. That's very much at work when you're learning a new skill or doing a complicated maths problem, for example. If you think of Sherlock Holmes taking all these disparate pieces of information to solve a seemingly impossible challenge, that's system 2. System 1, in contrast, is automatic, uncontrolled, effortless, fast, unconscious, and highly driven by our emotions. This is Homer Simpson instinctively reacting to his nuclear reactor buttons, who maybe don't want to think about, or deciding to get another donut. And we typically think that we're always using system 2. That's how we like to think we behave and how we make decisions. But in actual fact, some people think up to 95% of our decisions and our behaviours are made by system 1. And when we start to understand this, we can design the interventions and the communications and the programs we developed in a way that's likely to make them more effective. And I'm not trying to say that one is better than the other. So on the next slide, I'd like to try and read the words on this page. And you probably can, even though only the first and last letter of every word is in the right place. And that's because your brain's making a mental shortcut. It's using limited information to fill in the gaps and get you there with minimal effort. It's a really useful skill to have, but sometimes we have mental shortcuts that can trip us up and that get in the way of what we're actually trying to achieve. So if we understand these types of biases and shortcuts and how they might be influencing us, we can try to help us get to the right outcome or the desired behaviour. On the next slide, I'll talk through what's kind of a broad point that people often make, is that, yeah, that's all good and well if you're doing something that's a simple task, like choosing what tea to buy in the supermarket. But surely it's not relevant when we're making big, important decisions, like what should we recommend to our patients, or how should we interact with our EPR system, or what things should we buy. But actually it does. So this is known as left digit bias, and you'll often see it in every shop that you go to. They'll have things that are something 99. And if we think about it, we know that £4.99 and £5, there's actually, it doesn't matter the difference. And yet £4.99 feels cheaper. That's because we read the first digit first. And that gives us a sense of how expensive or cheap the thing is overall. And the researchers in this study on the right-hand side decided to look at this for patients being referred for coronary bypass graft surgery. And I'm not a clinician, so please don't ask me any extra questions on this. But it's a procedure that carries some risks, that does have benefits. But, you know, with time and with age, the risks and the complications might outweigh the potential benefits. So you can see there's kind of a gradual decline with age, the proportion of patients who are referred for this. But what these researchers did is they looked at the proportion of patients who were referred 2 weeks before and 2 weeks after each birthday. And you'll see there's a close overlap between the yellow and the grey lines across the board, except around their 80th birthday. So there was a statistically significant difference in the proportion of patients who were referred who were 79 years old and 50 weeks old, as opposed to those who were 80-year-olds and 2 weeks old. And we know, if we think about it, 1 month doesn't make a difference. And yet somehow the very fact that the first digit of their age had changed was seemingly having an influence on these highly trained people, these clinicians who are making these important decisions. So it can be applicable even when we don't expect it. So on the next slide, I'll take you through what do we do with that? So how do we actually change a behaviour? So I've talked a bit about what behaviour change is. So where from here? Well, in our team, the way we typically approach it is in a 4-step process. And this is broadly the same in most applied behavioural science teams that you might come across. First, we start with trying to define the behaviour. So what are we actually trying to achieve? Who needs to do what and when do they need to do it? Next, we come on to diagnosing that behaviour. So why might that behaviour be happening or not happening? What are the barriers and drivers? What might be influencing it? Next, we come to designing solutions. Once we know what is or isn't working, we can understand how we might be able to change it. And finally, we try to test it, because as good as something might be in theory, we only know if it works if we test things out. So next, I'll take you through the first 3 steps here with some tools and approaches that hopefully you can apply when you're looking at EPR implementation and adoption. So on the next slide, we'll talk about how you might define a behaviour. And I'm not an expert in EPR, as I'm sure you'll know, but there are lots of different behaviours that you might need your colleagues and yourselves to take part in order to get a successful EPR implementation. And these are likely to change across the implementation period. So you might start with really wanting to communicate the benefits of EPR effectively at the start, so people know this change is coming. So you might be looking at your teams who are communicating that. How might you help them to communicate these things effectively and use the right messages and not confuse the audience? So that might be one behaviour, is working with those people. The next might be with clinical staff. Once it's actually implemented, how do you get them to use it? So that's getting clinical staff to refer to the EPR system when they're treating patients at those key moments. And finally, you might be trying to get key decision makers to promote EPR. You might want them to say the right things and say positive things as you go through. Maybe that's in weekly communications. Maybe that's in every possible opportunity they have. But there's different behaviours that might be able to help you in getting to EPR implementation and adoption. And thinking about what those might be for your organisation could help you to create a more targeted approach and maybe be more effective. So once we've decided what behaviour it is we want to achieve, the next step on the next slide is to try and diagnose that. Oh, sorry, still trying to define it. Here we go. I'm on the wrong one. Thank you. So trying to diagnose it. So we identify the barriers and drivers using the COMB model. And this is quite a simple model. There's lots of different models of behaviour that can be used. And this one has synthesised lots of different literature to try and come up with a fairly comprehensive but also easy to use approach. And what it says is that for people to perform a behaviour, they need to have the capability, the opportunity and the motivation. If any of you are fans of true crime, then you'll know it's very similar to means, motive and opportunity. And it's quite easy to remember. So we're looking at, do people have the capability? Are they able to do it? they have the motivation? Do they want to do it? And finally, is it possible for them to do this in their environment? Each of these splits into two different components, which within them have lots and lots of different psychological principles and approaches. And I won't go through all of them, but I'll just kind of talk through some of the questions that you might want to ask yourselves once you've defined what behaviour is you want to change. So in capability, we're talking about physical capability. Can people physically interact with the system, for example? Can they see it? Is it legible? Do they have the dexterity to use it? Might be questions to consider. Next, in psychological capability, do they understand it? Do they know where to go for things? Does it require too much memory and attention for them to be able to actually use it? When we think about motivation, this can kind of split into reflective motivation, which is very similar to system 2 that we just described, and automatic motivation, which is more like system 1. The reflective motivation is, do they believe that this is useful? What's their attitude towards technology in general? Do they think that this has too many risks associated with it? How might they feel about it and what are they thinking? How might that inform their motivation? On the automatic side, they may have habits that get in the way. How have they always done things, and how might this new EPR system actually get in the way of that? How might they feel about technology? Are they quite unfamiliar with it and so they're a little bit scared, or do they love it and so they might be early adopters? Next, we come to opportunity, and we've got social opportunity, which is looking at how people around them behave. So are there people from other trusts who've had terrible experiences who say the EPR is the worst thing ever? How does that inform them? Or have they got people who are really great advocates for it and they see others using it really effectively? That encourages them to do so. In opportunity, we've also got environmental opportunity, which is more around whether people have the tools and the resources available. So is there actually enough infrastructure for people to effectively use EPRs in their day-to-day? Do they have to walk to the other side of the ward, whereas previously they wouldn't? How does that inform how they typically send out notes and so on? So if we think about it by breaking it down to these different areas, we can potentially see some of the reasons that it may or may not be easy to implement these changes. Once we've done that, on the next slide, I'll go through how we might go about designing solutions. And so typically we'd have defined a behaviour, diagnosed what's going on or not, and why that may or may not be happening. And then we'd use that to come up with really targeted interventions or strategies. We obviously aren't able to do that today. So instead, what I'm going to take you through is what's known as the EAST framework. And this is a very useful approach that for any kind of change that you're doing, any kind of behavioural intervention, whether that's communications or whether that's a new tool, whatever that might be, can help you to make that more effective. So the EAST idea or concept was developed by Behavioural Insights team, and it basically says we're trying to make things easy, attractive, social and timely. And if we do that, we're more likely to be able to get the desired behaviour. So I'll take you through each of these one by one. On the next slide, we'll start with the first one, which is easy. We have a tendency to be more motivated to do things that are easy. If you think about how often you might see one-click shopping, as the more clicks you have online, those tiny amounts of friction can actually really reduce how likely people are to follow through. And this is not rocket science, this is obvious. If it's easy, we're more likely to do it. But I think it's very easy to underestimate how big an impact that can have. So it's really worth focusing on this. So on the next slide, I'll take you through an example of where they've tried to make things easy in technology adoption for schools. So this was a new initiative in the US where they created an alert system for parents. And basically, if their child missed class, got really bad grades, anything like that, they would get a notification. And they wanted parents to enroll and to see how they could get them to enroll. So the control is nothing happened, there's just this program's available if you reach out and ask about it. And these were the interventions that they tested. The first one was standard enrolment. Every parent received a text message, explained what it was, and it said, if you want to sign up for this, call the school and then we'll give you the information you need. That got less than 1% adoption. The next intervention was where they made it easier. So they, instead of having to call the school, all you had to do was reply start to that text message. So that's already reducing the friction. That saw 11% adoption. But the one that performed best was automatic enrolment. So they all enrolled all the parents automatically, but instead the text message said, if you want to opt out, reply stop at any time. That saw 95% enrolment and a significant improvement in student achievement. So when we're thinking about EPRs, how might we be able to make the process easy? How might we simplify it? And are there things that we could do by default so people don't have to opt in? On the next slide, I'll just talk through one caveat here, which is similar to the point I made earlier about how easy it is for people to underestimate this. So they also asked key decision makers, so the district leaders, which of these interventions they thought would be most effective. And they all got the answers right, but they drastically misestimated, didn't estimate correctly the proportion to which that would be the case. So you can see they all thought automatic would be the best, but not by the same amount that it actually was. So don't underestimate how beneficial it can be to make things easy. The next one is around making it attractive. So we're trying to convince people to do something different. So on the next slide, we've got lots of things we want to do. We've got lots of emails that we've unread or guidelines that we really meant to go through that we may not have, or, you know, healthy habits that we wanted to adopt and we haven't quite managed it. But if we make it attractive, that can really help us to break through that. And there's a few different ways we can do that. On the next slide, I'll talk through one, which is familiarity. So this was a study where they tried to encourage more clinicians to recommend mobile health apps. But they found that actually if a patient went to the clinician and then got told to download an app, they didn't really feel like they'd been seen and they weren't really buying it. But what they did was they created a prescription pad where the clinician could just prescribe the app. And by doing so, they actually saw an increase in both the clinicians prescribing it and also patients from using it by keeping that familiar piece and translating it across. So how might we retain existing elements that have positive associations to make these new systems not feel so foreign and also have perhaps the kudos that we might expect of what's already there? The next slide, I'll also talk through something called argument dilution. So when we're doing something new, particularly if we feel passionately about it, we tend to try and throw all the arguments for that at people. It's like, this is brilliant for all these reasons. But actually, they're not all additive. So in this example, what they did was they tried to see how people would respond to side effects for a medication. And they found that by listing more side effects, when the extra ones listed were a bit milder than the main ones, so they added headache and dry mouth to things like memory loss and depression, overall people thought those side effects were less severe. They took the average of all of these side effects. It didn't make it seem worse as a medication, it actually made it seem safer. So when we're talking about trying to convince people with arguments through EPR, how do we focus on the ones that really matter and avoid diluting it by telling them everything that might possibly be good about it? Are we accidentally maybe diluting things for ourselves? The next one is around making it social on the next slide. So we're fundamentally very social creatures, and particularly in times of uncertainty, we tend to look to others for how we should behave. And so this example on the next slide, please, is around antibiotic prescription. And so what they found was that they looked for GP practices that were prescribing more antibiotics than they should, the worst performers in that regard. And they contacted them to tell them, actually, you guys are outliers. You're not acting like everybody else. And that's a bad thing. And in doing so, this very simple norm, this very simple letter, they actually managed to achieve the government's targets for antibiotic prescription reduction with one intervention. So it had a really significant impact. So when we're thinking about EPRs, are there already positive behaviours that we can share? How can we make the most of them? Or how can we make people who are outliers, and that's a negative thing, realise that and join with the pack? The next and final one is about making it timely. So when we try to get people to change, and when we present them with information, is really important and can have a big impact on how likely they are to follow through. And one that I think might be relevant here is in terms of the benefits. So on the next slide, I'll talk about how we can try to bring the gains forward. So with an EPR implementation adoption, it's a very long-term project, which Helen will be speaking about later. So the benefits might not be realised for quite some time. There could actually be a good deal of pain in the interim. So in this example, they looked at it's for a charity, and they're trying to reduce alcohol consumption. And the standard is to talk about these really significant things like, breast and bowel cancer and liver disease, and how those could be, how your drinking habits could be increasing your likelihood of these conditions. And people were kind of not too bothered. But actually, when they changed it to something that was more immediate, so saggy skin, obesity, premature aging, by flipping it to something that's more immediate, people were 15% more likely to take action. from the aesthetic and current problems associated with their drinking. So we can do the same thing with gains though. How can we make the gains feel relevant now? How can we make people experience small wins? Can we share immediate benefits of EPRs, not ones that are going to be realised in 5 to 10 years' time? So on my final slide, I'll just try and do a quick recap. So when we're trying to get people to change and we're trying to come up with interventions, whether that's communications or new programs, whatever it might be, if we try and make them really easy, attractive, social and timely, we can hopefully have more success. And with that, I'll pass on to Dave to start.
Thanks, Claudia. That was awesome. I really enjoyed that. So I'm just going to spend the next probably 8 to 10 minutes just talking through some personal experiences of how I've perhaps tried to stack the odds in our favour when we're creating both a business case or in fact starting the journey to creating, building and deploying an EPR. So one of the key things that I've always worked on, and it comes from some of the work that some of the tool there that Claudia was just talking about, is that it's really key early on in the journey and the journey towards implementation, procurement, wherever you are in the process, is to understand the drivers of the clinical teams. And I think when I talk about my experience today, I'm going to talk about the experience of nurses, AHPs, midwives, all of those clinical professions. The one thing that we found is a really useful and probably the most key tool for us when we're expanding ourselves into looking at what our drivers are, is to talk in a currency that people understand. I've so often seen outline business cases, full business cases being presented to clinicians, and the key bit that people will take away is the financial saving, the financial cost, the efficiency that they're expecting out of the system, the reduction in workforce, and all of the bits that turn clinicians off. Because ultimately, I think when people are understanding their EPR journey, they want to understand what it means to them. And for us, and this is a personal experience, using the currencies of releasing time to care, releasing time to treat, and releasing time for patients to live their lives is probably a far stronger currency to utilise. And what I've found, and what the team that I work with are finding at the moment, is that we're pulling that throughout the entire journey. So we don't lose sight of that time currency at every stage. So whilst there will be a financial benefit, whilst there will be a benefit to the teams as a whole, let's work out how much time we give back to our patients and our staff, and indeed those caring for our patients. There's no doubt engagement throughout is absolutely key. And one of the things that I've worked on recently, and I'm working through a business case with colleagues at the minute, is that we started to engage with large clinical teams even before we got to the stage of looking at the procurement, before we even got to engaging with suppliers. We've gone in early to talk to staff about what does the pathway change look like. This isn't about buying an EPR that's the best one that we've all heard of or the best one that fits the organisational fit. This is absolutely around understanding when we redesign a pathway of care or a pathway of treatment, will we have a supplier that can come alongside us that will deliver that pathway change? And so as the second driver that I've always utilised alongside time is, what does our pathway look like? Now, I'm really fortunate to work in an organisation at the moment that is acute community and mental health, and talking to suppliers, trying to cut across that breadth of delivery of an EHR is really challenging. So being able to describe that pathway to both the suppliers and the teams that we're going to work with is absolutely key. So develop it early. And I've said here, one of the key things I've said is bring a comm specialist in early. If I could give any advice to any clinical team going through an EHR procurement or building an EHR system, is absolutely get a comms team that can deliver your message for you. As clinicians, we talk really well to each other most of the time. As clinicians, we talk really well to patients and carers and the population really well most of the time. but actually they spin it in a language that we understand, and the comm specialist will just develop that space for you that gives a very, very different outlook for the teams that you're wanting to talk to. And comm specialists can synthesize words in a way that perhaps as clinicians we can't sometimes, so absolutely get them on board. Next slide, please, Sam. I talk to this because in my previous role I was an interim chief nurse, and somebody said to me, you'll never be able to get amongst your teams like you did before in jobs that you did previously. And in the job I'm in now, in a strategic job, people say the same. But actually, I've used this tool now for the last probably 3 to 4 years, which is never underestimate curiosity. And that's your own curiosity of understanding what your teams around you deliver. I've made huge sweeping assumptions in the past about what a nurse specialist might do for a living, or what an ACP does, or what a therapy consultant does in their day job. And actually, living amongst them and walking amongst them for a few hours, understanding and talking to them at the moment when they're next to a patient, gives you a completely different perspective, and it allows you to draw that into business cases, into procurement conversations, into conversations with suppliers in a way that you won't if you don't understand part of the pathway. I know we say it all the time, but you know, walk in other people's shoes. And I've talked here about engaging at every level. And when I talk about every level, I don't just mean within our own professions, but I mean within the whole spectrum of people who work across healthcare. We've had some fantastic housekeepers that were able to describe to us some of the really key pathway changes we could make at the start of a patient's entry into a ward or department environment that I'd never thought of. Getting away from single-use cartons or using single-use cartons so you could scan juices as part of a dietary need, or taking away some of the complexities about ordering food 48 hours in advance and building it into a pathway of EHR makes a completely different pathway for a patient going through our systems and involves people at every touch of the system. I think what I've said here is about visibility of all teams, and that's about the interconnectivity of teams and understanding where they touch each other on a patient's journey. And unless you walk with your teams, you won't see that. And I've talked about encouraging feedback and reflecting back what people talk to you about. And another key tool that I've used over the last probably 4 years of my career, particularly in the digital environment, is the utilisation of reverse mentoring. And I'm going to talk a little bit more about it in the next slide. What I talk about here is inclusivity, and when we're designing an outline case or a strategic outline case for an OBC, or we're starting to get into the early days of understanding what our patients need, I'm talking about inclusivity here in the realms of digitalisation. So what I've done in a number of programs that I've worked with now is understood the digital maturity of both the patients that we're going to work with and that we treat, and the digital maturity of our own workforce. It's really difficult to understand that. And this here is a model of Somerset where I'm working at the moment. And this is a heat map of the potential digital exclusion across our county. And what we had to do is, and what you can do is take some assumption from this is, you will have staff and people who are going to visit the hospital living in these areas, and you can make some wide assumptions in the early stages of developing your pathways and your EHRs to understand the digital capability. You can see we've got a little few red spots across the county there. They are in areas of socio-economic lower income areas within our county where we've got some level of exclusion, and we have to recognise who works in that space. So when we're talking to our teams and talking to our patients about moving to a new system, we need to bear this in mind and work out how we can create an inclusive model for patients and staff who might struggle in a digital environment. Next slide, please, Sam. So some small tips. So this is my last slide, and I think what I talk to here is the reverse mentor piece. I have 3 reverse mentors at the moment. One is a student nurse, one is a healthcare support worker, and one is a band 7 nurse in the mental health environment, because I'm not a topic expert in mental health. So I want somebody who's going to challenge me when I talk about how impactful a digital system is going to be to teams, and that brings me a different language that I can use with teams across the organisation. And I'd really recommend reverse mentorship. Alongside that, fast comms, and this is where your comms expert comes in. Those quick snippets, quick little ditties that resonate with teams. So a little something that says, actually, if we design it in this way, we believe we could, for instance, give 8 minutes per nurse per day back to releasing time to care. That little snippet of why. I also say, get a brand that sticks from day one. I've worked with 3 EHR systems being developed over the last 4 years. They've all had a brand that have stuck, and I think it's really important to get that early. People buy into a brand if they understand its rationale. And then what I talk about here before I hand over to Helen is that at every opportunity, talk about your programme. It doesn't matter what forum you're in, but drop in the rationale into that specific forum as to why you've got a new digital program underway, or that you are developing a case for a future digital enhancement. It just adds something to every little forum. And at that stage, I will stop and hand over to Helen. Thanks very much, Sam.
Next slide, Sam. So thank you very much. I'm Helen Balsdon. I'm Head of Digital Nursing at NHS England, and I was previously Senior Nurse for Informatics at Cambridge University Hospital. I too, like Dave, I'm going to share some of my experience, because for me, PR implementation is about changing everything we do, whether we do that in a fast way with a big bang go live, or whether we do that over a period of months and years with a slower rollout. So some of the key issues for me that I've got in my next slide are really about what that means. And I think it comes back to change. Change for some can be really hard, whereas others, probably like me, really enjoy it and really enjoy actually, what are we trying to do? Let's make it better. Let's make it there. But that human response can really dictate what people's behaviours can be. And I've put a few out there, and they're things that I've seen over time, and some of them are at different stages of the process. I think in relation to EPR, the biggest one that I've seen, not necessarily in nursing, but it does apply, is that piece about standardisation, to the point where standardisation sometimes becomes a bit of a dirty word, because people think they're going to lose something. The way they do it is different, it's special, and it means something. And I often think there's lots of some people that are really special, but they don't all have special needs. And we've got to address that concern of that loss of autonomy, what we're trying to do, because we're not going to build multiple ways of doing it within an EPR. We're going to build one way of doing it, although the system might be able to do it several different ways. In my next slide, I very much wanted to call out that process of transition, because it's different for different people. And it's important to remember this is a long-term journey. This is not a sprint. This is a marathon that's going to take you many years. The Cambridge experience that I was part of took 7 years to get from implementation to a high level of digital maturity at HIM stage 7. That's not quick. There's different things along the process. You have to take different stakeholders. Your workforce changes. You know, a lot of those things that different people know at different places. And the more staff you've got, the more complex that can be. And you want to reach everybody. But those people are going to be in different places at different times with their levels of emotion and their response to that change journey. One of the things we really saw at our go live was a lot of our doctors, and this is well documented, were really, really angry and didn't enjoy it. From a nursing perspective, they were going, I don't know what they're talking about. This is great. I can read their writing. Let's get on with it. And so 2 very big workforces coming at it from very different perspectives. And it's really important to not judge, but actually just look at it for what it is, because you are changing everything. And work is such a big part of what we do. It becomes really emotive. But I've got a few top tips in my next slide. about the things I think are really useful to support a successful implementation and adoption. And many of these, both Claudia and Dave have said before, but it's about leadership and teamwork, but engaging as well. And it's leadership and teamwork at all levels. Just because you lead across an organisation doesn't mean to say you know everything. And actually, it's about ward level leadership. What is the healthcare assistant doing on their shift? How can you make it easy? What does that look like? How does the team deliver great care when they're looking after a number of patients? And it's about being able to get that information, really understand it and start using it. I've put in circumnavigation there because I think it's really important to remember where accountability for the decision lies. Because one of the behaviours we saw in our go live was people want to go talk above. They didn't want to, if they weren't getting what they wanted from one group of staff, i.e. the digital leaders, they went to talk to the executive or the NEDs that were coming around the hospital. And I think it's important to go, that's great, everybody listen. It's really important. We sit and we listen, but always refer them back to who makes the decision ultimately, so that there's consistency and everybody gets that clear message. And really trying to harness it so that it works, and not to be afraid to have those difficult conversations. Some of what we saw, not a go live, but was when we're looking at the rollout of barcoded medicines administration, wanting to change practice on 56 clinical wards. Well, they each administered different ways. They each had a different footprint. Some had trolleys, some had cupboards, some did patients' own drugs, some didn't. And it's really important to understand that level of detail, but also come to a consensus about, so what are we going to build? What does that look like? What is good practice here and what's not? And they're hard conversations to have, but they're really, really important to surface those professional issues, but surface it with teams in mind, so that you're taking people with you on that journey. And actually the product you give them goes back to what Claudia said, make it easy. Make it easy to do the right thing, because that's what you're trying to do. Be honest, but also manage expectations, because I found that people thought the system could do everything, and it's like, it might be able to, but at the moment we're going to focus on this. Be clear about what that looks like, so that you do take people on your journey, but involve them in that prioritisation, so that they are part of that change and actually have a contribution to make to that. The engagement piece, I think Dave's covered beautifully, and I think it is, there's no one size fits all. Do something, keep doing it again, re-evolve, reinvent. It's different ways, and that will change as your journey goes. But having somebody that can lead communications with you at all stages of those journeys is really, really important, because your messages will change. And it's important that somebody helps you work some of that through and uses the language that's going to engage the professions. So we mentioned barcoded meds administration, and I've got lots of people going, well, we're going to roll this out because it's what we need to do to get to the HIM7. It's like, no, we're going to do this because this is the safe and most internationally recognised way of working that improves patient safety and makes nurses, more effective, and actually improves what they do and how they do it. And so it's that language of communication that comes back time and time again. What's right for your profession? Knowing that and using that is really, really important. Engage and involve. I think involve for me is something that really comes up time and time again. I put together a nursing informatics steering group to really go through what was in the record, and we had some really tricky conversations. How did they practice? What was care planning? How are we going to do it in a digital world? It surfaced lots of issues, but it was absolutely fabulous for helping nurses, midwives and our support workers really understand the variation that we'd got and get them to go, oh, that's really good, I could adopt that. And what we saw as a result of that was great scale and spread, because they wanted to be the best. And I think, especially to start with as well, coming back to creating insight, Dave had a slide there about visit. Go visit. Go visit. Get people coming to you as well, because sometimes you can't take lots of people on a visit to another hospital, even if it's the one next door. But in this new virtual world, get them to come and present to you in a digital world. I remember going to University College London virtually to talk to them about what was the day in a life of a ward sister. I didn't just do it, I did take a ward sister with me, you know, working in a digital world. What was the role of the matron? What was the head of the nursing? And we were actually able to engage on scale without actually being in the room. So lots of different ways of doing it, but there's nothing quite like hearing it or seeing it and then going, so how's that going to work here? What will that look like? Training is another one. It's not just a go live thing, it's a long-term thing. Something about how we personalize the system to make it quick as well as easy to do the right thing, but also your system's going to evolve and there'll be different upgrades. So making sure everybody can use it and keeps reinforcing, because some of the stuff you teach before you go live, you probably will have forgotten 6 months later. So there's nothing quite like going back through that loop to help them. And remember, you're in it for the long term. You're absolutely there. So pace yourselves, prioritize, take time, do it well, but actually evolve and adapt, because you'll need different tools in your toolbox at different times, and be ready to evolve as leaders in a digital world, as well as supporting the different tools to engage, involve and help people really adopt a good EPR. So at that point, I'm going to end as well. I'm going to pass you back to Dorothy.
Thank you so much, the three of you. That was a fascinating session, and there was so much information packed into that 45 minutes. It's going to be phenomenally useful that we've recorded these sessions, that they're going to be available to people to go back and look at some of that information that you've shared. And of course, we will be sharing the slides. We don't have any questions posted from our listeners, but I have one for you. With a couple of minutes that we've got, and it's not tough. I'm not trying to trip you up, but the question is this, and I'm particularly thinking about those people that are on the call that are going to be leading or participating in this adoption, and taking their colleagues with them, and managing all of the challenge that they also get, as well as the support that they get. How did you personally cope with going through this change, and what support did you or are you seeking for yourself to help you get through and manage this change? So really about yourself.
I think at Go Live, I gave myself 3 weeks to work as many hours as I needed to work, but I absolutely called it at 3 weeks. And went, I'm not doing any more, back to normal, it's business as usual. Because you have to look after yourself. You can't sustain silly hours in the longer term. But it is also about actually helping others take the load off you. So you've got self-care for yourself, but it's not all about you as the leader. Actually, you've got other people that you're getting ready to step into your job. Co-production is a good piece. Let others lead those pieces of work and you bring it all together. That would be my top tip.
Great. Anything to add into that, Dave? I'm conscious that you're partly through your journey. A second time.
Third time.
Third time.
I agree with Helen. Is that this cannot be beholden on one person at any time that you do this. The size of the teams that are built now to go through these programs is enormous, and there's a huge amount of expertise formulated now across the country of people who've done this, and lots of people are there to give you that advice and the moments of when to step back and the moments of when to get close to it. And I think, you know, absolutely utilize the strengths of the team, and I would really suggest doing a bit of an understanding of the key strengths of your team early on, so that you know who's your completer finisher, you know who's your detail person, you know who the person is who's going to work later in the evening, not earlier in the morning. Get a real understanding of those people, because that way you share the load in a way that you can't if you try and take it on your own shoulders. And you know, and it's looking out for colleagues who try and do the same. So, you know, it is going to that team ethos piece. So I completely agree with Helen.
Fantastic. That's a great note for us to finish on. Thank you so much. Just to let everybody know that we are going through a process of editing these sessions. They will be made available. We'll let you know when they are. You should be getting an evaluation questionnaire out tomorrow. We've done this with all of the sessions. We really seek your feedback so we can do the best job with these sessions that we can possibly do, and that may well contribute in also a workshop at Rewired, and I'd encourage all of you to attend Rewired. We've got a great nursing event coming up next March in this particular session of Rewired 2023. Next week's session is all about optimization. Lots of people have asked us about how do you really get the best out of your EPR system and the long-term benefits to nursing AHPs and midwives. And just a reminder as well that there is an EPR community of practice on the hub, and the link is there. Please do, if you're going to go through adoption of an EPR, join that community. I see the chat going on through that all of the time, every day of the week. There's great advice and great support for you there. That's the end of today's session. Thank you so much for joining us, and we look forward to seeing you next week. Thank you very much.